past, you spent 6 years as a treasurer, and then 2009, a vice president of the American Head and Neck Society, and 2013, you are the president. Now, your interesting path came from your undergraduate. So you spent some time, you had your undergraduate degree from University of Toronto, and then you went to private practice. And then from private practice, went into advanced fellowship in Head and Oncology Reconstructive at University of Toronto, and moved to University of West Virginia, and then Buffalo. Now you're a full professor and director of program at the Oregon Health Science University, where you're currently the director of the residency program and also the microvascular fellowship program. So I think the sort of a obvious question was that what sparks your initial passion into head and neck reconstructive surgery from private practice, and what kept you going?
Well, originally I started out in private practice in Canada, and the healthcare system's a little different. Resources are much more limited and much more managed, and so the ability to do complex surgery is more difficult in a non-academic center. And so I wanted to do more with my career. I liked private practice. It was a lot of fun. I enjoyed my patients. I enjoyed the people I worked with. I wanted to do more than just practice. I wanted to do more from an academic, more technically complex. I wanted to sort of do more difficult type procedures, and I really loved head and neck surgery. So I went back, did my head and neck fellowship, and at the time there were no jobs available in Canada, so I moved down to the United States and went to West Virginia, and that was a great job. I loved everything there, and I loved being a head and neck surgeon. I loved the ablative part, the patients, treating people with head and neck cancer, improving their outcomes, giving them better quality of life. And I moved to Buffalo, and I continued to expand. And then an opportunity opened up here on the West Coast. We'd lived out east for a long time. My wife's family was out on the West Coast. It looked like it would be something interesting, and they were looking for a reconstructive person. And the people at that time at OHSU were pretty, some very big names. And so they recruited me and said, would I come out and do reconstruction? And I said, sure, it'd be a great opportunity. And so that's when my career path developed for reconstructive surgery. The ability to, we're pretty good at taking out tumors. There's almost every operation you can think of has been described by someone, at least 1930 or so. Anesthesia has improved our ability to take out tumors. And so really the next frontier was being able to reconstruct them to decrease their morbidity, decrease the complication rates. And then now I think what we've done is we've gotten beyond that. We're all good at reconstruction, and we're just moving now to rehabilitation. So we can remove tissues, but the goal now is not so much just to put things together and get them out of the hospital. It's to put things together and improve their quality of life. And knowing that we can make them better and bring them back to some semblance of normality as best that we can.
That's fantastic. So that brings me to the next question. So one of the things to establish normality is to reestablish function. And you are one of the early pioneers adopting the VSP, so virtual surgical planning and 3D printing in mandible maxillary reconstruction and dental rehabilitation. So I guess, do you want to give us a bit of a sort of an overall view of what's current state at play at the moment, and where do you see this technology heading, and where would the reconstruction be heading from this aspect?
So the ability to simulate on a computer platform our reconstruction used for bony rehabilitation, not only maxillofacial, but we work with the neurosurgeons a lot. They're using it for cranioplasty to make custom design cranioplasty implants. I think that's taking us the next step. So that's the rehabilitative role. I think we were very good at putting mandibles back together, so we could put the mandible there and the bone heals, the morbidity is less, we get good cosmesis, but functionally, patients, at least in many patients in the United States, at least, and in North America, don't get implants because they were expensive. But the implants and the patients have expanded. And so now more and more patients are now eligible for implants. And I think maxillomandibular reconstruction with free tissue transfer has advanced with more amelioblastomas, benign maxillary tumors, trauma. And so now we look at the rehabilitative phase and we go, well, we want to be able to get teeth in there. As I'm a otolaryngologist, head and neck surgeon, and for me, one tooth looks like another tooth. And so you just go, well, great, we'll put the bone in there and you make teeth. And that's sort of like telling my colleagues in facial plastic surgery, well, one nose looks like another nose. I mean, trim a little bit of this, do that, and everybody's going to have a great looking nose. And they're going to look at you and go, you just stay doing what you're doing. So if you want to be able to get people to get teeth and to get implants and to get dentures, it's a lot more work to line up the mandible, to get the pieces in the right spot. And three-dimensional modeling allows us to be able to do that. There's no question that there are Michelangelos in the surgical field. I have colleagues that can look at the x-ray and go, I'm going to just take that straight piece of bone and carve it, and I'm going to make this beautiful. And God bless them, they're wizards. They can do that. But I think for the rest of us, being able to model it in 3 dimensions on the computer and simulate saves us a tremendous amount of time. It lets us put the bone in exactly the place where we want it to be. And it really helps with our healing and with the ability to plan for implants down the road.
Your approach for the VSP and dental rehabilitation, there are multiple different approaches being described by surgeons around the world, like the Rona approach, where you do this sort of prefabrication beforehand, or the art approach on Edmonton, where they're sort of being planned in the sort of the inset setting. Do you have a preference to any of those approaches, and what's your algorithm in working through this complex reconstruction?
So it's a good question, and I think that what eventually is going to be, what eventually evolves in 5-10 years, I'm not sure that we'll, I'm not sure where we're going to be. I think that there'll be an excellent algorithmic approach that lets us take someone that has a tumor that we're going to resect and then plug them into the system and be able to come out with teeth. For benign disease, the ability to do, I think it's similar to the Edmund approach. I think they've done it at Sinai. We've had a few that we've planned here. We call it teeth in a day, where they come in, they get their tumors resected, they get their free flap, they get their implants put in, they get their prosthesis or a temporary prosthesis made, and they go home looking like they have real teeth. I think that's a goal. And for the people that can do that, it's a wonderful thing. The dynamics and the administration and the ability to get it done is huge. It requires interaction between multiple specialties, a hospital system, and it's exceedingly complex. And we ourselves have not got there yet. We've got all the pieces, but getting everybody together, getting it all done, getting it, in a timely fashion, having everything lined up, getting the right patient, we haven't quite got from A to Z. We've got to Y, we've gotten close there. I think that we're going to see more of that as time goes on and as it becomes easier. I'm sort of reminded of parathyroid surgery, where it used to be that we would, if we wanted a PTH doing parathyroid surgery, I would take the blood specimen, I would go cross campus to a different building up to, the 15th floor of the basic science lab, hand it to a tech, and then I'd, spend 20 minutes wandering back to the operating room. And now, you just sort of they take the specimen and the PTH machine is in the operating room. So I think all of that is dramatically going to improve.
Definitely. Now, in 2014, you did your trilogical thesis on the utility of Doppler ultrasound in free flap monitoring. In terms of monitoring your flap, is this still your choice of flap monitoring, and do you have experience in other form of monitoring? such as the tissue oxygen measurement or the surface infrared monitoring. And do you have any views on all these sort of sophisticated monitoring systems?
Yeah, I think, whatever system works where you are that allows you to get a good outcome, then that's the system that you should use. We use the Cook-Schwarz Doppler on the artery. Um, and I would say, a significant amount of time we use the flow coupler device. I think it's it's a Baxter. It's made by Baxter, and so we'll use both of those in some patients. And I think that the monitoring device allows us to have the nurse in our floor and in our specialized care units to be able to come in and just flick a switch and see if everything's okay, or to look at the flap and see if everything is okay. Um, I think anything that gets someone in the room to be able to be aware and then to be able to intervene is what the important thing is. We have not had experience very early on with the tissue oxygenation. And it was not very efficient for us because most of our flaps were in the oral cavity. There's saliva, there's all sorts of bodily fluids that seem to interfere with it. And perhaps the technology, I'm sure, is continuing to improve. Where exactly we'll end up, I'm not sure. But I think, whatever system you have, if it works for you and your salvage rates and detection rates are good, then that's the right system to be doing. So we're at a teaching hospital, and the Doppler system, works well for us.
When it was interesting because when I was with Fu Chen Wei visiting him and did a sort of a mini fellowship with him, they did a review about the sensitivity on and also cost effectiveness of different monitoring system, and they came up to be if you are in a country where the cost of nursing staff is not very high, that is probably the best way to do it, which is a straight needle pricking rather than any other sort of fancy monitoring system. So your comment on what works for your institution definitely stand, because that will be the most robust system that monitor your flat.
Yeah. Yeah, it's interesting because we did do a study on, we used the arterial Doppler and the flow coupler, and we use them, both of them. And we looked and we found that if you use both of them, rather than just one, about 1% of the time, so it was about 3 out of 200 patients, it may have made a difference. And you're right, my department was split right down the middle. There were half that said, that's a huge cost for such a little yield. And the other half said, oh, but you're saving a flap and it should be no cost. So clearly, whatever resources that you have available, sticking it with a needle works great.
That's true. I thought I would follow up there because during my fellowship in London, we and that sort of was then published in Laryngoscope, following your many years after your thesis. We look at that, and as we adopt that system, we find that there's a lot of false positives. So a Doppler signal missing, but the flap is still okay on the venous outflow. And so the venous seems to have a lot of big learning curve compared to the arterial Doppler. Would that be your experience when you adopt that system?
Yeah, so this is just my personal opinion and my personal experience. So you can't take this as, oh yeah, this is the gospel or whatever however you want to put it. So we originally tried to use the Cook-Schwarz Doppler on the vein, and it didn't work in our hands. I have some plastic surgery colleagues that it works great for them. So it must just be my technique, or it doesn't work for me. So I can't put the Cook on the vein. The flow coupler works on the vein. We can't use the flow coupler on the artery. I'm not sure in Australia what it's like, but in the United States, most patients that get free flaps have some degree of atherosclerosis of their vessels. And so trying to use a coupling device on the artery just doesn't seem to work. So the flow coupler, you're right. when I look at it and I go, it's great, it's not a problem. But if you ask my residents or my fellow, they'll tell you that it's about maybe 10 times as intrusive on their evenings and on their time than another coupler, just because you're right, the flow, it'll suddenly disappear. And so they'll drive into the hospital, look at the flap, they go, looks good. And suddenly they hit the switch and boom, it's back. Can't explain it. Was the blood volume pressure low? Did it wasn't enough flow to pick? I don't know. So yeah, it can be a little bit resource intensive with the flow Doppler. But like I say, it has saved, to us, a significant number of flaps. I think that each individual system and surgeon needs to weigh, all of those issues, the system issue, the cost issues, and decide if it's worthwhile for them in their setting.
That's fantastic. Now, I'm going to change my topic a little bit on ablative and reconstructive. Now, immunotherapy has been an emerging field in head and neck surgery. We've been subjecting lots and lots more patients for immunotherapy. Most of it in the adjuvant setting, but the neoadjuvant are coming in. And then the salvage caseload are coming in with patients that failed immunotherapy. Now, I haven't got a lot of salvage experience on patients that failed immunotherapy. So do you have any of those experience, and what are the challenges in operating this group of patients, either both ablative and reconstructive?
So it's interesting you asked, because I saw your question, so I had to go back. There was a group of us from the AHNS Recon committee looked at from a collaborative multi-institutional perspective, because like you say, everybody has 1, 2, 3, 4 cases, and that's just, well, in my experience, so we put together a series of patients that had immunotherapy either before, after, or both before and after, and it does appear that it does have an effect of healing. And it seems to be that it's most likely at the recipient site. So donor site complications seem to be the same. So the radioform, you put the split thickness skin graft or the fibula, those sites seem to heal the same. But the recipient site, so the composite resection in the head and neck, those sites seems to have a higher incidence of complications. But again, those are patients that have been heavily pretreated. They've usually had chemo, radiation, previous surgery. So is it the immunotherapy, or is it the fact that you've pre-selected out a very bad category of patients that's, has bad nutrition, has all the wound healing characteristics that none of us want to see, and we put the free flap up. And as a free flap surgeon, once you put the flap up, suddenly it doesn't matter that the patient's malnourished, had chemo, radiation, and 5 other operations. It's the flap that caused the problem. So it's probably the patient population were predisposed to the morbidity. I think when we looked at patients that had immunotherapy or immunosuppression, which isn't as big as the immunotherapy, but immunosuppression for heart transplants or lung transplants or kidney transplants, they all did pretty well from a wound healing perspective.
True. With the immunotherapy, do you have experience where you were salvaging for the partial responder, not a full responder, where you were salvaging while they're on immunotherapy? Do you notice any difference to those that are non-responder that you have to stop immunotherapy, or in your review with the society?
I think most of that's anecdotal. And I think that there are some patients that they get salvage therapy and they just have terrible wound healing problems. And then there are other patients that do well. And like most things in the head and neck, it's being able to discern, who's going to do well and who isn't. I think that, if we see patients that are on immunotherapy and require further salvage surgery, then we always counsel them, and we're prepared to offer them both their reconstruction, free tissue transfer if they needed, but with the understanding that their wound healing is going to be is not going to be as good.
Yes, that's really good. Thanks for that comment. Let's switch back to one of the last question, which is probably one of the important question, which is more sort of as a mentor and as an educator. So you are the director of the resident otolaryngology program, also director of the microvascular fellowship program. And I'm not quite sure in how much of that movement, the sort of the safe working hours, the Me Too movement been affecting, been sort of infiltrating the training program, but certainly is a big thing in Australia, certainly is a very big thing in UK, where the hours are really being clamped down. And here, there's no move where you will have to do 1 in 3 on call, not a 1 in 2 or 1 in 1 on call. So that all impact on the experience as a trainee. Where do you see the challenges now to get someone through the training program, like get someone trained up as a microsurgeon?
So, I think that I think we're probably here in this country still way out in left field or right field, depending on which side you want to pick. I think in Europe, and I'm not sure in Australia, but you're looking at 46. I had a fellow once; they were like a 46-hour work week. We're 80 hours, and if you think about it, 80 hours is a lot of time. So we're an 80-hour work week for our residents. For our fellows, there are no regulations on our fellows. They're still like junior faculty. So they work, whatever hours that they want to come in. Otolaryngology in this country is a difficult specialty to get into for a surgical field. And so it's highly sought after, and you don't really get into otolaryngology unless you really want to. So it's you spend a lot of time shadowing, you spend a lot of time seeing other otolaryngologists, and you get a good feel for what your lifestyle is going to be. And some people come in and they go, I'm not going to pick on one of my partner's specialties because I know that'll just come back and they'll beat me up over it. But maybe you want to do subspecialty A, and that's 9 to 5, 4 days a week. One of our out in private practice, and you just accept that it's going to be more labor intensive to get the training so that you can get that job. And then there are others that want to become head and neck surgeons, or they want to become skull-based surgeons, and they know that that's going to be a much more different lifestyle and different hours. And so I think they can select that out during the course of their residency. Residency, at least in this country, the first 2 years are pretty intensive. They're 80-hour work weeks. And I think that some of the difference from what we have and from my understanding of the UK and that particular type of system is our residencies at 5 years, you're done, you're good to go. And I think some of the other residencies, they take a lot longer before they graduate or before you get out there. So our residents, their first 2 years, it's a lot of work. And then after that, depending on the service, they can put in 40 to 60 hours a week. And I tell all the residents when they're first starting is, I can make it easier. I can give you a 40-hour work week. It just means it'll take you 6 or 7 years. And all of them go, nah, I'll spend 80 hours a week for my first 2 years. And then after that, it gets a lot easier. But in 5 years, I'm going to graduate and I'm going to get a job.
That's that's certainly a little bit different to we are somewhere in a hybrid between UK and US. Where there's some time that you spend to gain experience before you go into the training program. Once in training program, you're somewhat under that sort of. There's no clear cut. There's not a 40 hours rule or 80 hours rules, but what is required. The only thing is that the on-call system has changed to 1 in 3, which is enforced by the college due to. Some of the injuries some of the residents has occurred during the training because of overwork. So some of the things, because when we're on call from home, not at hospital. So there's a lot of driving involved.
Yeah, our call is 1 in 4 in hospital, and then if you take home call, then there are some hours depending on how busy you are, that kind of thing. But not very many people monitor the at-home call, the
That's
phone
right.
calls and the rest.
So as a sort of a director of a microvascular fellowship program, it is sort of, I mean, microvascular training in a non-plastic setting is still quite a foreign concept in many countries. And certainly in Australia, we are moving towards where North America is heading, but we are still far away behind. Where sort of what sort of changed that approach in North America, where sort of that being taken over more through the head and neck unit, and where do you see this heading?
So honestly, I think what happened was, plastic surgery, in the town where I live, orthopedic surgery, we're doing the free flaps for much of the head and neck practice. As more otolaryngologists became interested and expanded in the field of head and neck surgery, then the demand for head and neck surgery, it was always there, but now there were more people to do it. So rather than me being the sole head and neck surgeon with all these patients that needed to be taken care of, I now had partners that were going to do it. And so I wasn't as busy as I used to be. And as I became less busy, we're all type A personalities. We go, well, I want to still be just as busy. And we began to say, if I want to do my case and I want to, do a free flap, or I want to be able to reconstruct them, there's no question that as the ablative surgeon and as the otolaryngologist that works with speech therapy and language and all of the rehabilitative specialties, that we're the ones that learn the most on how to reconstruct someone. And rather than just taking a piece of tissue and plugging the hole, we try and do it so that we can get a better functional and rehabilitative outcome. And then it's a scheduling. If I want to schedule my surgery, then I schedule it with myself or my partner, and we arrange that. Whereas if I have to reach out to another specialty, it then becomes a negotiation of when do I get to do the patient. You are in clinic on Tuesday, I'm in clinic on Wednesday. Can we operate on Thursday? You're out of town next week. It becomes an issue. Whereas if it stays in-house, we can always manage to get it done. And I think all of those factors expanded as the otolaryngologist began to do more and more of the free tissue transfer. Until now, I think almost every institution, there's a number of institutions in our country that don't do, otolaryngology does not do their own free flaps, but in almost all institutions, they do their own free flaps.
That's
You're either in a setting like ours where, I do 180, 200 flaps a year for, the whole place, or you're in a setting like another institution that has 3 or 4 people. So we have 3 or 4 head and neck surgeons, and each of them does, 30, 40, 50 flaps a year, maybe more, some number. And that seems to be the 2 different models.
that's fantastic. What for people, for any trainee who wants to be either from otolaryngology or plastics or general or maxvax, they want to be a reconstructive surgeon or microvascular reconstructive surgeon in a head and neck oncology setting, where do you see that pathway is? And people always talk about how long does it get you to get there, or what sort of training do you need? You've been in this sort of training field for a little while. What's your general guideline advice for people who wants to be in that space?
So I think there's a number of ways of getting there. Obviously, since I'm an otolaryngologist doing head and neck and doing recon, that's the best way. If you want to do recon and you want to do microvascular, then an otolaryngology residency program and then a 1-year fellowship is usually the way to do it. Microvascular reconstruction for the head and neck is not part of the generalized otolaryngology training. So you may come out having scrubbed a bunch of flaps or done things, or certainly seen a lot of them, but usually you have to go off and get some extra training if that's where your career wants to go. Oral-Maxillo surgery. One of my partners is an OMFS, and he has spent some extra time. Same sort of thing. They have a much longer training program because they go through dental school and then they go through OMFS, and which is a couple of years more, and then they get an MD degree, and then you can do your fellowship either in head and neck, or you can do it in micro. It depends on where you are. The OMFS program here out in Oregon, they get a ton of head and neck. So you wouldn't need to do a head and neck fellowship. If you wanted to do recon, you could do a year of recon. Other programs, they don't do as much head and neck, and so they might need to do 2 years of fellowship, but it would depend. Plastic surgery comes out. Again, depending on the institution, they're very well trained in micro. It's just part of what they do. Their exposure to head and neck micro is not as good, and so they end up needing to do a fellowship either in head and neck recon, just so that they can find a job if they want to go somewhere that does head and neck. There's a few places where plastic surgery continues to dominate, micro, and they do a great job. But there's not that many opportunities in the United States to be doing it that way. Orthopedics, they do their own recon. They do a lot of hand surgery. I mean, reconnecting a hand, I mean, that's complex. I mean, that's amazing. Bringing up free tissue transfer for a mandible compared to a hand, I mean, that's easy. But the orthopedic surgeons, I think, are busy enough doing what they're doing that none of them want to touch anything in the head and neck.
That's fantastic. Professor Wax, thank you. We've covered sort of the core topic that we wanted to sort of cover in this interview. Do you have any other comments about sort of the reconstruction head and neck that you want to share with us, or sort of a word of advice or words of wisdom?
Well, I think it's a dynamic field. I think it's going to continue to develop. 3D modeling is sort of like that parathyroid, that PTH machine. Right now, if I want to do 3D modeling, I arrange something. I do an online session. So I think the one we use is in Belgium, I think. I'm not sure. And then, they send it out and they get it made. I think what's going to happen is that kind of stuff is going to become all in-house. There'll be the technology. My residents will be able to figure out the technology. We'll be able to design it. We'll be able to print the plates with 3D printers, or maybe the company will have a printer in Portland. And so that's going to cut out the time. And I think it's going to dramatically decrease the cost, I think, which will help a lot. Tissue engineering is, huge, and I'm not sure it'll happen in my career, but the ability to cytokinetically drive stem cells to form muscle or to form bone, and then we just need to put up our tissue to reconstruct with some form of vascularized tissue. I mean, I think there's a huge potential there. So I think there's a lot that's still going on and a lot of direction that we can move in.
Yeah, I think just to pick on that comment, you're right. The turnover time can sometimes be a challenge in the 3D modeling and BSP, especially if you're dealing with sort of malignancy that need to be sorted out within a very limited time frame. Now, the reason I brought up Rona was I had a chat with Rona recently, and they sort of were able to offer that for their oral STC group through the Rona approach, and they approach things quite differently. They do a plate, they close things, and then they come back with a flat a short time later. So take away the oncology, separate out the oncology from the reconstructive, and that probably one of the model that can be moved towards for the more sort of for the more advanced sort of cancer, rather than just a medulloblastoma or the benign cases for the ORN. But that still, I think there's not many a doctor for that technology. They are resource intensive, and they are very specific skill set that the whole unit need to adopt. And certainly the very specific technology that unit need to adopt to be able to offer that sort of work for patients. So there's a lot of challenge in that, but there's a lot of excitement, a lot of development, and a lot of research, and that can sort of be pushed. And there's so many models now for the VSP that I don't think there's one model that sort of outperform others at this point in time that become a clear-cut winner.
Yeah, we do a fair bit of reconstruction for the orthopedic oncologists, and they have the same type of model. They'll come in and they may resect the tumor and then put a wound vac, and then we'll come back and put up a free flap 3-4 days later. They check their margins and they do whatever they need to do. But it's a resource driven practice. From the otolaryngology perspective, we don't have the hospital doesn't have the resources to give us if we suddenly said we want to take out the tumor, get our margins, get everything set, and then we'll come back in a week and put up the flap. We're struggling to get our cases done now. So maybe once COVID settles down and, we get more resources and the beds are back to normal, it certainly is. We do some of that with the Mohs surgeons. So it's certainly an interesting approach.
It is. I think we'll watch this space, and hopefully the journal PR will continue to support publication in this field, to be able to for us to evaluate the different technology. With that, Professor Max, I'll thank you for the opportunity to and then also to devoting your time for this interview. Might hand it over to Lillian and Mark to see if there's any. Do you want to make any comment at the end?